Lakini
It doesn't even bother.
We regret to announce the death of our staff,
Welcome, ladies and gentlemen, to this amazing session once again. You are all welcome today in today's session. Today we are talking about blunt and penetrating chest trauma. Speaking is Mugisha Cleophas. I'm the emergency medical technician based in Mbarara, and I'm glad to be here. I welcome you all, and thanks for participating. So we are going to have a brief introduction of the experts and the team members who will be on the panel discussion today. As I'd already introduced myself, one expert next to me can introduce himself as well.
My name is Dr. Kabweru Wilberforce, and I'm a consultant general surgeon. I head department of Cardiothoracic surgery in Mulago National Referral Hospital.
Thank you very much, Doctor.
Osire John Andrew, critical care nurse, Mulago National Referral Hospital.
Thank you very much, Mr. Osire. So we have also other experts, and the one who will be presenting our case today. Dr. Justine, can you introduce yourself?
Yes, good afternoon all. I'm Dr. Justine Athieno. I'm an emergency physician at Mbarara University of Science and Technology. I'm an emergency physician at Mbarara University of Science and Technology, but also I work at Mbarara Regional Referral Hospital. I'm happy to facilitate today. Thanks.
Thank you very much, Dr. Justine. We are going to have also Dr. Najemba Margaret, who will introduce herself, who is our case presenter today.
Good afternoon, everyone. Yes, I'm by names of Dr. Najemba Margaret. I'm an intern doctor at Mulago National Referral Hospital. Yes, I welcome everybody for this session.
Thank you very much, Doctor. We are going to have a recap of the previous session highlights, and we'll go forward with the case presentation thereafter. So you can give us
Thank you very much. My name is Dr. Agaba Brian. I'm the clinical advisor of SID Global Health. I would like to welcome you to this 32nd session of the Emergency Medical Services ECHO. Thank you very much for logging on, and we hope to have a good session. Before we start the session, I have two pieces of communication. One is about the REACT teams, that is the resuscitation action teams that are being formed in several hospitals with the aim of improving management of emergencies in the emergency department and the general hospital at large. So SEED Global Health and Ministry of Health have visited several hospitals in several regions, constituting these teams. I think you've seen some of these activities going on and more are planned. So far, we have managed to reach districts in the south, in the west, in the east, and in the west Nile. And in the coming weeks, we shall reach the north, and we shall be setting up these teams. Please, if you see the Ministry of Health officials and officials from SEED Global Health in your hospital, please take part in this if you are passionate about emergency medical services. Second, I would also like to congratulate those who finished phase 2 of the emergency medicine services session, which was titled Approach to an Unstable Patient. It had a total of 7 sessions, and if you attended at least 5 of these sessions, you will be awarded a certificate. Right now, we are sharing a sample of the certificate that is going to be awarded to participants that managed to attend at least 5 out of 7 sessions. So we shall be awarding this in the coming days. Thank you very much. Over to you, moderator, to take us into what the experts have prepared for us. Thank you.
Thank you very much, Dr. Brian. This is very interesting because your efforts have not been worthless. If you have a certificate, it will be able to help you once and in future. So it is a very good initiative by SEED Global. Thank you very much. Now we are going to go to the case presentation. Dr. Margaret, over to you.
Okay, thank you, modulator. Dr. Thomas, I would like you to help me share the presentation that I sent. Okay, so it's about blunt chest trauma. It's going to be presented by me, Dr. Najemba Margaret, okay? So we received a KH, 28-year-old male, a motorcyclist with no known chronic illnesses, who came in with a prior history of being involved in a road traffic accident 2 hours ago, where he collided with another motorcyclist, fell off his border into a trench by his right side of his body. After which he developed worsening generalized chest pain, exacerbated by breathing and change of position. This was associated with difficulty in breathing without cough or palpitations. He reported a headache, loss of consciousness for some time, which was recovered, but there was no history of convulsions or vomiting. He reported history of another accident that had happened 4 months ago, where he never sought for any health care, and he sustained a chest pain that he could manage with over-the-counter analgesics. So on assessment, airway and C-spine, he was in obvious respiratory distress. However, he was able to talk and support his neck. Breathing, he was tachypneic with a respiratory rate of 36 cycles per minute and SpO2 of 92%. On room air, where oxygen via nasal prongs was given, and the SpO2 was able to be shot to 98. The chest was asymmetrical. Right side wasn't able to move on respiration, had generalized tenderness, and absent air entry with reduced breath sounds. However, no added sounds, and had a stenoidal percussion note in the right hemidiaphragm, and the left hemidiaphragm was normal. So an emergency right chest tube underwater sewer drainage was inserted, and we were able to drain 1 liter of bloody fluid on spot. Circulation, had warm extremities, had no pallor, was tachypneic, was tachycardic, sorry, with a pulse rate of 120 beats per minute with a strong pulse, BP 124 over 70 millimeters of mercury, and capillary fluid was less than 2 seconds. IV fluids were given. Disability, the GCS was 15 out of 15. The pupils were equal and reactive to light, had a soft neck, normal power in both limbs with limited range of motion of the right upper limb, and had intact sensation. So an armrest was improvised. Exposure, he had multiple facial, forearm, and scalp lacerations, which we were able to suture, had posterior and anterior chest wall bruises, and abdomen was of normal fullness, and IM diclofenac was given at that time because of pain. And EFAST, which was done, had a right-sided hemothorax to rule out an pneumothorax. So we planned for a chest X-ray and a brain CT scan furthermore. So for secondary survey, signs and symptoms, had a difficulty in breathing with chest pain, which was worsening on moving the right hand, facial and scalp lacerations, anterior and posterior chest wall bruises. He had no allergies. Medication last took unknown analgesics 5 days ago for the other chest pain. Past medical history, no known chronic illnesses. HIV status was not known because he last tested 5 months ago with no history of surgery. He last ate lunch, which was around 5 hours ago. And then he collided with the other motorcyclist and he fell off a border into a trench. Problem list, we had a right hemothorax, squaring a rib fracture with a mild traumatic brain injury. So follow-up, a brain CT scan was done, which was normal. A chest X-ray showed a massive right-sided pleural effusion with fracture of ribs 5, 6, and 7. So the CTS team, cardiothoracic surgeons were informed, who reviewed the patient and admitted the patient to their ward for chest drain monitoring and further management. So IV antibiotics, ceftriaxone and metronidazole were prescribed and given start dose. IMTT was given, IV paracetamol, and also IV fluids. So the chest drain was monitored while in the CTS ward for around 10 days, where they did a repeat chest X-ray and it had a cleared hemothorax and a chest tube was removed. So the patient was discharged on oral antibiotics and analgesia the following day to be reviewed in 2 weeks in the CTS clinic. Thank you.
Thank you very much, Dr. Najemba, Margaret. Members who are attending, please, they are going to send a pretest in the chat and you attempt it. So as you attempt the pretest, I'm going to briefly go around the pre-hospital management of this chest penetrating and blunt chest trauma. Meanwhile, as you answer the pretest, then from the pre-hospital, I'll give you the first expert who will take us on the first management principles in the hospital. So you can go to the chat section and start answering the pretest. So mostly in these in the pre-hospital management, we look at the emergency medical care. That is what we really need to focus on in the first principles. So first and foremost, we need to keep our basics intact, the ABCDE. So we need to assess and maintain a patent airway. And we should do this by doing a jaw thrust. This time, remember, this is trauma. Then other considerations which should be paramount, we should consider spinal immobilization as a paramount point. We should consider spinal immobilization as a paramount point because we may cause more injuries to these people who have gotten the chest injuries because it is around the same region. Then we should go to breathing after airway. Now with breathing, we need to really look around and assess the breathing adequacy. So we need to assess and ascertain the breathing adequacy. So by this, we need to first assess for breathing. After assessing for the breathing, then we can address the breathing. It depends on settings which we are working in. Some people are working remotely, maybe with no well-stocked ambulances, but all you have those ambulances that are well-stocked, you would high-flow non-rebreather mask. Then you should give 10 to 12 liters if the breathing is still inadequate, and occlude any punctures to the chest wall by doing a 3-sided dressing, as they usually teach us in pre-hospital management. Then saturation, we should assess the saturatory components. So saturatory components we should assess and establish a solution immediately. So if at all there is massive hemorrhage, we should arrest the hemorrhage and then rehydrate immediately. So give fluids. Then we should give fluids until we assess a systolic pressure of 80 to 90 millimeters of mercury. Then you should do a pulse check, skin color changes, and you do those very fast. Then you control the major bleeds. Then with everything else, you need to provide that full immobilization. Then you initiate safe and quick transport to the hospital. But as you do each and everything I've talked about, you should evaluate each step you finish, whether it has been addressed or not. Then later, you need to record the vitals and keep on monitoring and addressing each vital as you see it. Each abnormal vital, you should address it there and then. It is very important to monitor one part before you go to the other one. If airway is not yet corrected, please don't move to saturation before you correct airway. Then when you're handing over, you really need to hand over systematically. Hand over giving the vitals, giving the information about the casualty, the incidents that were surrounding the casualties incident. Then you give out even the handover report, including the medications you would have given. Or you have given, and you give a recommendation on what you need to be done to the casualty or patient. So now with all that pre-hospital care, it's done very fast and in a limited resource setting, usually in our areas, mostly up country. So now after handing over these casualties or patients to the hospital, you give the full report, and now this is the time to hand over to the ED person, the emergency department nurse or emergency department doctor. So it's at this point that I give you Mr. Osire to take us through the ED assessment and care of this patient. Over to you, Mr. Osire.
Thank you very much, my brother. Yes, on receiving KH who was involved in a RTA road crash, with the report I've received, still I will further not take it for granted, still do run a quick assessment of my ABCs, airway. Maybe during transit you may find a tooth that was loose has dropped in the airway. Assess for that. Maybe separations have increased along the way, suction involved. Just all I need to ensure is there patency of my airway. Then we can also move on to breathing. This patient breathing, yes. Is there equal bilateral air entry? Yes. Auscultation, what do I hear? What is my breathing rate? How fast, how slow is it? So all that I need to make sure that my C saturation, pulse, is it there? How fast? How regular? BPs, this is when I now take note. I have to go and check my blood pressure, not forgetting I just have a few gadgets here that I'm trying to show. Check your blood pressure, pulse, run them and be sure that the patient have received his stable. Then D, disability, check GCS, confirm the patient is awake. Score. A, don't forget, because on my department, this is where I now need to, any suspected head injury, trauma, I now have to assemble. It says in the hospital we have cervical collars. I have to put the cervical collar onto this patient KH unless proved otherwise that there's no spinal injury at this point. I then go further, on my assessment, I have to ensure that I have established, I place my 2 light bulb cannulas, so that this would aid us during resuscitation for easier management of this patient in case the patient crashes during the assessment. I take off my blood samples, run my baselines, electrolytes, RFTs, and whatever the doctor may still need us to run. Normally, these patients who have such injuries, chest injuries, blunt traumas, will always complain of pain. So what pain management do I have to give? I have to now liaise and ensure I am managing pain at this stage in the emergency department. Oxygen, I have to position this patient in a comfortable position, preferably sitting position, and administer my oxygen accordingly. I have a pulse oximeter in the hospital. I may have a better pulse than this, pulse ox than this, and ensure my SATs are within my acceptable ranges, starting from my nasal prong, simple face mask, NRM, and above, depending on how the patient is picking up. Then I also run another assessment of my GCS under D. So from now on, all my findings I'll be having, we may also need to have some imaging, X-rays, CT, depending on what we need for further assessment. I now hand over my patient to my emergency physician, and we work as a team. Thank you so much.
Thank you very much, Mr. Osire. Now, from the initial assessment, we go to the secondary and senior assessment by the emergency physician in hospital. Now, over to you, Dr. Justine Athieno, can tell us about the extended survey and assessment of this patient.
Thank you so much. Can you all hear me clearly?
Yes, I can hear you. We are all hearing you.
Okay, let me just share my slides. Yes, so as the topic is today, we are really discussing the approach to a patient with chest trauma, and that's both blunt and penetrating. And I really like the fact that we've already had some discussion on the pre-hospital aspect, but also the in-hospital nursing bit, because the nurses are the ones who normally triage. But as the patient is waiting the triage bay, what are those things that can be done? And thank you, Andrew, for putting that out there. So for starters, this is what we are going to try and discuss. And please do use the question and answer section to ask anything that comes to your mind about management of these patients. So we shall try to go through what chest trauma is, and I'm very happy that Dr. Kabweru is on. So I'll be asking him to chip in once in a while as we go through this presentation. It's going to be really engaging and less of didactic, okay? I hope you're all ready for it. And then we shall go through basically identification and management of life-threatening conditions within the chest. And then where do these patients actually end up, okay? So to start off, really, chest trauma is basically looking at trauma within the chest region. And as you can see in the pictures that are projected, the number of organs that are within there that we worry about. And of note is that we have the thoracic cavity. Let me try to, okay. I think you can all see my pointer now. Yeah, we have the thoracic cavity, but still within the chest, the rib cage, we also have part of the abdominal cavity. So when you're thinking about chest trauma, both blunt and penetrating, you need to have that in mind, that it might not just necessarily be within the thoracic cavity only, okay? So here we can see the heart, the major blood vessels, the lungs that are nicely elaborated here, but pulled away. The heart has been pulled away, and then you can see what's beneath the trachea, but also we have the esophagus behind here, okay? So it's important for us to have these organs at the back of our minds as we think about how we are going to approach these patients, okay? So just like Dr. Najemba presented, it's usually very important to know the mechanism of injury of these patients. But from your previous sessions, you've already been told about the initial assessment, how you need to address the things that are going to kill the patient first as you go through before you get the history. But when you have enough hands, it's absolutely important to know whether it was a head-on collision, if it was a border rider, did they have a helmet on, because then that changes the whole mechanism and some of the injuries that you might see. If I was driving a vehicle, did I have a sudden stop and then my chest hit the steering wheel, and now I'm coming in with chest pain? So the mechanism of injury kind of really gives you an overview of the injuries that you might expect as you're assessing your patient, okay? Some of the mechanisms that are implicated in chest trauma, blunt, mostly are the ones we see, but once in a while we get penetrating injuries, and actually they account for most of the deaths related to trauma, penetrating chest injuries, okay? So for blunt injuries, as you can see, they are mostly acceleration, deceleration injuries, and basically the organs within the chest are stretched. And if one is attached to, for instance, the aorta, you have an area that is attached to the wall, to the thoracic wall, and one that isn't. So when you have those deceleration, abrupt stopping, okay, so the organ also comes in and then just suddenly stops. So you have shearing mechanisms. So those are some of the things that explain blunt trauma. Whereas for penetrating in our area, we rarely have things like gunshot wounds, but those are some of the penetrating mechanisms, gunshot wounds. But what we normally see in Uganda, because we are in a fairly stable environment, we don't have so many conflicts, and we are not a war-torn area. So most of the injuries that we see that are coming in with penetration are mostly like stab injuries, or like you have a spear impaled in the chest. So those are the ones that we mostly see. And therefore it comes from the direct injury of this object to the organ that it gets in contact with. But it's also important to note that if I stab you with so much force, you might fall back and hit your back, okay? So there are also secondary forces that come to, in addition to a patient coming in with just penetrating trauma. Okay. So next, I had already mentioned that it's important for us to think about the other aspects, especially where your diaphragm ends, okay, and where the liver starts and the spleen. Because if you come in with a stab wound, then those are some of the things that might be injured that are not just within the thoracic cavity, okay? Yeah. So moving on to the initial assessment. So when a patient comes into the emergency department, like the previous speakers had mentioned, the most important thing that is going to kill the patient first is the airway, okay? And there are particular things that we look at that are going to present mostly in chest trauma patients than in any other, okay? So when you were doing the initial assessment, they told you need to begin with the airway. Within the airway, really looking at things that are going to obstruct the airway, isn't it? Okay. So within chest trauma, some of the issues might be, you might actually get active bleeding from the airway, and these patients are actually not able to speak because they are bleeding out. Okay. Once in a while, they might get actually massive hemoptysis, and as you're suctioning, it's continuously coming through. So these are patients that you need to actually think about advanced airway management early on as you're approaching the patient. If you find them with a lot of blood in their airway, you're suctioning, you're putting an OPA, and it's still not helping, this is a person you as the REACT team member need to think about really fast calling in somebody who has advanced airway skills. And with this, I'm meaning somebody who has intubation skills, okay? Because you might need to go in with a definitive airway that will help you suction, but also these patients will be able to be managed depending on where the source of the bleeding is, okay? If it's in the trachea versus if it's coming from one of the hemithoraces, okay? So there are so many measures, but for this talk, I'm not going to go into the details of what is done in the active management. What we need to know is that we can have active bleeding from the airway, and we should be worried and quickly activate a senior anesthesiologist or EM physician, but also in mind have the ENT surgeon who can actually do an interventional bronchoscopy and be able to embolize this bleeder and, you know, be able to save the patient, okay? But all the other basics in airway management still apply. Position your airway, put in an OPA. If they can't tolerate it, put in an NPA, keep suctioning the airway as you wait for advanced care, okay? The other thing that is quite common in the airway of a patient who has gotten chest trauma is subcutaneous emphysema. So this is a white patient that I put for you here, but I recently saw a patient who actually got extensive subcutaneous emphysema. Fortunately, they did not progress as much to actually require advanced airway management. The problem with this is if you have a patient coming in with bilateral chest trauma, okay, mostly penetrating, okay, and then you have this patient, perhaps they required some form of ventilation, so you're bagging them, whatever has gone through the pleura, okay, because you know with penetrating, or if you have rib fractures bilaterally, someone needs to mute. Sorry. Yeah, if you have like rib fractures bilaterally and you get like pneumothoraces bilaterally, but also with rib fractures, you can also have some slight subcutaneous emphysema. But if this patient undergoes positive pressure ventilation, okay, where you're putting on a mask and you're bagging them, this emphysema can actually expand, okay? And if it extends over the chest cavity and goes to the neck area and surrounds the neck, it can actually cause constriction, all right? So that's why when you're seeing a patient who has gotten chest trauma, look at the neck area and make sure, and also palpate, make sure that you don't have any emphysema, because if it expands, it can actually obstruct your airway from the outside inside, okay? So in management of this, of getting an advanced airway in early enough, if you can get them intubated, but the tracheostomy is actually much, much better for them. The other options are to put subcutaneous drains, and this is the point where I'm going to ask Dr. Kabweru to give us some of the cardiothoracic aspects and perhaps what he advises, because literature says that actually the subcutaneous drains sometimes don't really work that much. So Dr. Kabweru, I'm going to invite you to talk about this at this point. Thanks.
Thank you very much. Can you hear me?
Yes, we can hear you clearly.
When you have subcutaneous emphysema, it is very important for you to actually, when you look at this gentleman on this slide, there are two things that you're looking at. You're looking at the ballooning out of the patient, but then what we are most worried about is the mediastinal shift. So if you have extensive subcutaneous emphysema that is involving the intrathoracic or the pleural space, in most cases, what we advise you put a chest tube so that you drain over time. But then the only challenge comes when it is due to bariatric trauma, especially of the lungs, where you don't have any connection within the pleural space. That one tends to become a very big problem, and if it continues expanding, it may actually take the patient. So we usually say you do a chest X-ray and then assess. There's some other mechanisms usually that is advised to use. Those subcutaneous stab incisions, but they also risk the patient getting infection. So it is always paramount to do a chest X-ray and see whether the pleural space is involved, and then you can drain, obviously, as time goes by. And make sure your walls of the chest tube are all within the pleural space. They are not within the cutaneous, they're within the subcutaneous area. Thank you.
All right, thank you, Dr. Kabweru. We shall move on. So next from the airway, we normally go to the breathing. And here it's where we actually assess the effort of the breathing. If patients are in difficulty, they're having shortness of breath, but also there are particular things that we look at in a patient with chest trauma, okay? Because we are talking about the chest, and the breathing aspect is really to do with the lungs. So this is like the biggest area that we really need to emphasize, right? So just like in the assessment, you start by assessing from observation. There are some things that might actually come out to you as you're seeing a patient coming in post-trauma by just looking at the chest, okay? The expansion is absolutely, how is the chest moving with respiration, okay? And are there some areas within the chest that are not moving synchronously with the rest of the chest? And this might talk about things like a flail segment, okay? Whenever there are changes within the intrathoracic space, the segment goes up or down as the rest of the chest cavity is moving in another way, okay? And also looking for bruising patterns, because they also give an idea of which particular organs might be affected. If I have a bruise around the sternum, then I know that the organ that is beneath the sternum will probably be mostly affected, okay? And that's the heart, okay? Whereas if I have a bruise around the upper chest, okay, then I'm worried about the upper lobe of the lung, okay? So bruising patterns are actually very, very important. The other aspect that comes in when you're thinking about penetrating chest trauma is looking, if a patient comes in with a wound, you have to observe if that wound has some characteristics that are in line with a sucking chest wound, okay? Because then that tells you whether there is communication between the pleural cavity and the outside, and accumulation of what we call an open pneumothorax that we'll look at later on in the presentation. So from observation, we go to palpation. Palpation is quite important because that's where we are able to diagnose some life-threatening conditions like a tension pneumothorax. And starting off, I like to start off because it will tell me a lot about, besides what Dr. Kabweru mentioned about a huge subcutaneous emphysema, it will tell a lot about tension in case there is a pneumothorax. Okay, so if the tension has built up severely, then your trachea is going to deviate to the other side. I think we've ever demonstrated that skill. So you make sure you actually check for your tracheal position. And then as you're palpating, this is the time for you to actually palpate for the crepitus. And that is where you're going to diagnose your subcutaneous emphysema. How far does it go? Up to the neck? Is it down? Where is it, the extension? Because your initial assessment will also help in monitoring this subcutaneous emphysema to see whether it's expanding or it's actually remaining stable or it's resolving. Okay, so the crepitus here is when you palpate the skin, you feel like you're pressing, can I say paper? You know, when you cringe paper and then release it, that sound, you're able to feel it beneath your fingers in the subcutaneous space. But also the other thing besides feeling for the crepitus is you're able to feel for any discontinuity of the ribs. Like if you just palpate along the ribs, each of the ribs, you're able to feel for any discontinuity, but also tenderness over the rib cages. And then that can give you an idea of what perhaps might be happening and how you might be able to help the patient. Going back to Andrew's presentation, this is perhaps when you would pain score your patient and find out how tender it is around there. Then the next in the assessment is percussion. Percussion is absolutely important because it helps us distinguish between a pneumothorax from a hemothorax. Dr. Najemba presented a patient who came in with a hemothorax, okay? So percussion is absolutely important because if you have a tracheal deviation, you have hyperresonance, meaning it's loud, it's like a drum, okay? It means there is air that has accumulated in that hemithorax, okay? There are other aspects on top of that that will be very helpful, like distended veins, like a low blood pressure, like we'll see later on. versus if you have a hemothorax, which will be dull to percussion. So make sure you percuss the patients if you can. Then auscultation is really for you to assess air entry in both lungs, but also to assess the breath sounds. Do they sound normal in all the lung regions? Or are there areas that have reduced breath sounds? And it also speaks to the extension of either the hemothorax or the pneumothorax, okay? Now we shall go into how we can assess but also manage some of the life-threatening conditions, starting with how to, I had just described how to differentiate a tension pneumothorax from a massive hemothorax. And as you can see in the picture, with tension pneumothorax, you have air building up within the pleural cavity and it's pushing, okay? Pushing that lung towards the mediastinum. And the more pressure builds, all the mediastinal structures will be pushed towards the other hemithorax, okay? And it comes in with lots of other issues. Besides, of course, having difficulty in breathing, reduced oxygen saturation, and also we had mentioned the tracheal deviation. These patients, because of how restricted or how the pressure around the heart builds up, okay, their venous return is impeded, so they don't have enough to actually pump out, okay? So they end up getting what we call obstructive shock. So a patient who is having a tension pneumothorax always has obstructive shock, and that's evidenced by reduction in blood pressure, systolic blood pressure below 90, but also distended blood vessels, distended neck veins. Okay? And if you're in a setting where you have ultrasonography, when you look at your IVC, if you're not able to visualize, if you look at your IVC, it will be distended despite the fact that the patient has just undergone trauma. So that is a patient. And to mention, tension pneumothoraces are clinical. It's a clinical diagnosis, okay? And that's why it's absolutely important for you to first examine your patient before you start sending them for x-rays. Because if a patient comes in with this tension pneumo and just send them for an x-ray, this is a patient who will die at the door of the emergency department, okay? You need to first rectify this before you send them out, okay? So if you examine your patient and you find any of these findings, hyperresonance, percussion note, tracheal deviation, distended neck veins, and then a low blood pressure, know that you have a tension pneumothorax. And the next thing to do is a needle decompression, okay? As you're planning to put your chest tube. All right. The other thing, perhaps you can actually go there and discuss the needle decompression aspect. So with needle decompression, the classical, as I mentioned, this is a temporizing measure as you're planning for your chest tube, okay? Because the ultimate measurement, management of a pneumothorax, especially one that's under tension, is you need a bigger caliber of a tube to go in and just remove that. But because that normally takes time to prepare, there is a temporizing measure, which is needle decompression, okay? So this is where you go through the chest with a large bore, catheter, or cannula to try and relieve some pressure, okay? So the classical location has always been the second intercostal, and as I mentioned this, I'm also going to invite Dr. Kabweru at the end to also give us what's happening in Uganda. But the classical location for needle, the classical location for needle decompression is the second intercostal space. As you can see in this picture here, the second intercostal space, mid-clavicular line, you just go over the third rib with a cannula, a large bore cannula, you go in, and as soon as you aspirate some air bubbles, just remove the trocar and let the cannula be, okay? The problem with the needle decompression is that it's a very small caliber, okay? Those cannulae are not large enough. So if a patient actually has a proper tension pneumo, it's not going to relieve as much pressure as you would need. So that's why actually there are some people who put multiple needles if the blood pressure doesn't improve, okay, as they are trying to get a chest tube in. The other aspect that I noted is that right now there's a change from the classical location, especially because the population is moving towards the higher BMIs, like obese people, but also those with bigger mass, like chest mass, the ones who have built their mass of a long time. That cannula around the second intercostal space, the failure rates are noted in a study. The failure rates were noted to be higher when you go through the second intercostal space than when you go through around the fourth and fifth intercostal spaces in the either mid axillary line or the anterior axillary line. Okay, and mostly the anterior axillary line approach was found to have less failure rates. And that's why right now there is that changing recommendation, even with the advanced trauma life support, that for children, absolutely second intercostal space, mid-clavicular line, and perhaps with also adults that are smaller bodied. But as people get bigger, it gets more successful if you go via where you normally put your chest tube, and that's around that area. Yes, Dr. Kabweru, do you have any comments around that needle decompression?
I have.
Yes.
Needle decompression is very key in our setting. And remember, you have a tension pneumothorax. There are two challenges or problems that you are trying to solve. You have a collapsed lung or atelectatic lung, and then you have poor cardiac output because the heart has been put or pushed to the other extreme end, and it is unable to expand. So the role of the needle what we call thoracostomy, is to actually put off the pressure from the heart so that saturation is not impaired, because you have already, if the patient is already in shock. And we usually second intercostal space, we say it is safer because of the reason that we know that when your lung collapses, it collapses towards the high lung. That's close to the sternum or high lung. So when you put in the second intercostal space, there are no chances of injuring the lung. The only challenge that you will face when you use the fourth and fifth intercostal space, especially on the left side, is to injure the heart. That will be the other thing. And then on the right, we know the liver span. If for those people who have enlarged liver, you may run into the liver. But then all that said and done, after the needle thoracostomy, you haven't sorted out the biggest problem. You know, we have one-way valve. The air goes in, is entrapped, is not coming out. So you want to solve the problem. So after your needle thoracostomy, you will get a gush of air coming out. Now saturation is improved, that is C. But you have a problem with breathing because this person is not expanding the lung. So we encourage you to use the third, fourth, or fifth intercostal space, and you put in a chest tube. Now for adults, if even when you put in gauge 24, 26, or 30, it will drain. Yeah, you can put even 26 or 18. Children, 18 would be very okay, and then school-going children, 24 would be fine. So it is always good as you are managing the patient and you are putting your needle thoracostomy, please call by the way, the doctor can put in a chest tube. It is only that the heart that is missing. So we usually train, and we train 50 years, we train interns, we train other medical officers, we train general surgeons, we train everybody and fellows. So we expect that most of the regional referral places and then A center falls. Now I think with this patch model, even A center 3s, people would be able to put in a chest tube. So we expect you to put the chest tube and then solve the second point, that is the lung expansion, because it's already collapsed. And you know, that is very key, because if you don't do that, you'll end up actually with a pneumonia. And if it finds a patient who has COPD or a patient with comorbidities, or a patient who is unstable with other chronic lung injuries, this patient actually may not survive. So this is a preventable death. I usually say, please stick in the needle. You palpate the rib, and you go in that space and go above the body of the rib. Because when you go below, you risk going through the intercostals or the neurovascular bundle. That's the nerve and then the vein and the artery. The intercostals, they run in that groove below the rib. So you palpate and go above the rib, and you should be safe. Thank you.
Thank you, Dr. Kabweru. As you were mentioning chest tube insertion, I also just projected some images here. And what to note is that we always talk about the safe triangle there.
The angle of
And
safety.
it's in line with what Dr. Kabweru was saying about injuring, yes, injuring the going through the diaphragm, but also if you go below that, then you're already in the chest, I mean in the abdominal cavity, and the likelihood of you going through the liver or the spleen is very, very high. So think about that angle, that triangle of safety that you're seeing here projected as you're putting your chest tubes, okay? And like you've mentioned, Dr. Kabweru, absolutely every doctor should be able to put in a chest tube, okay? So in case we have some medical students on, make sure you leave medical school when you've learned how to put in a chest tube. The other aspect is I know that with some medical pleural effusions, we might just go in and just put either a urine bag or whatnot, but with traumatic hemothoraces, okay, or in case you're thinking the patient has a hemopneumo, it's absolutely recommended for you to put this patient's tube in an underwater seal drain, okay? Because we are there, even though all you saw was just fluid, okay? So absolutely make sure you put this underwater seal drain, and this is a setup. We know that we always improvise. I didn't put pictures here, but we always improvise with a bottle that you can make sure there is an area where the tube goes underwater, and then there's an area for the air to come out. So I don't know what you use in your settings, but absolutely make sure you have an underwater seal drain as you drain the either pneumo or hemopneumo or hemo.
Dr. Justine, can I make a small statement?
Yes, please.
Thank you very much. That angle of safety is very important. You know, if you hold your anterior armpit, there's that fold, the anterior axillary fold, and posteriorly, there's also a posterior axillary fold. So if you draw a line in between those two, that is the middle axillary fold. And you see that person was raising the armpit. And that area there, that if you look at that angle there between the third, fourth, and fifth, those are safest places that you can put your chest tube. If you want to drain air, you point your chest tube superiorly and posteriorly, or behind and up. You know, air is less dense. So it will always settle above water if you have. Sometimes you have both fluid and air. So you push it posteriorly and superiorly, and you should be able to drain. Now, if you want to drain fluid and air posteriorly, and if you have what we call angled chest tubes, then you can push one down and then the other one up, and you drain both. Now, the length of that chest, that tube from the underwater seal should not be very long. If it is very long, then you get a lot of atmospheric pressure that will not enable you to drain. So it should be appropriate, around 75 centimeters, or between 50 and 75, not more than that, or at least up to 100 centimeters. If it's beyond, then you won't drain, because there will be that atmospheric pressure that will oppose drainage. If it is also too short, then you risk things being sucked into the chest and contaminating the pleural cavity. Now, in Uganda, we have underwater seal drainage bottles available on market and they're affordable, and some of them are donated. So I wouldn't expect somebody to use improvised bottles, because the complication rates of patients that actually we're operating these days because of these injuries, that patients end up with empyema thoracis are very high, and patients have lost their lungs. We have ended up doing pneumonectomies, lobectomies, and it shouldn't be good. So let us use the appropriate things. And I don't want to encourage a lot of improvision. I know in most schools it's like there is a course unit called improvision, but I think it should be put aside and we use standard things. Thank you.
Thank you, Dr. Kabweru. I wish and hope that some MOH professionals are here to make sure we actually have those underwater seal drain setups in all the hospitals. Okay, so moving on. So the other aspect that I always think about when I'm assessing a patient with chest trauma is a patient who's coming in and they have a wound on their chest, okay, as I'm assessing them. So the key question that comes to my mind is this penetrating chest trauma? Is this wound sucking, or it's just chest wall injury, okay? So assessing like this guy's wound here, it's absolutely important for you to assess and see if this wound has any communication with the pleural space, or if it's just chest wall injury, okay? And some of the things that help me is, like I mentioned, from observation, you would be able to see some aspects. If it's a sucking, whenever the patient breathes in, they create negative pressure within the chest wall, okay? And if this is connected, then you see a flap of it being sucked in, okay? And when they are breathing out, they create positive pressure within the chest cavity, and you see this flap being pushed out, and then you feel like, so it's like a sucking wound. So if you see that thing, please and please do not just cover that wound like you're preventing bleeding, okay? Because I think Dr. Kabweru actually alluded to it, that if you just close off, if you have a pneumo that is being closed off, then it will just, because it has nowhere to come out, okay? It will just expand, especially if you're getting air getting in through another way. So if you find something like this and you're able, so if you find a sucking wound that I've just described, that is, and it will form an open pneumothorax, because every time you create negative pressure, air is being sucked into the pleural cavity, okay? And sometimes these wounds actually create a one-way valve, where it can only suck in air, but it can't push that air out. So you need to absolutely make sure you diagnose that clinically. The other things that help me is if this wound here, there is a lot of surrounding subcutaneous emphysema, okay? Because it means that air is coming from somewhere around, and it has to be within the lungs, because that's the organ that contains air. So if this wound has subcutaneous emphysema around it, and then it's sucking, then I suspect an open pneumothorax in there, okay? Or I suspect a sucking chest trauma, a sucking wound. And the management of this is what we call a three-way dressing. I think one of the facilitators mentioned a three-way dressing. It's mostly important in the pre-hospital setting, but also in the in-hospital setting where you don't have resources immediately available. You will need to put this as a temporizing measure, okay? As you're mobilizing your chest tube, you need to put this so that you prevent that air going through as you're mobilizing the chest tube. The other thing is, if your patient is going to undergo positive pressure ventilation, like if they are having perhaps reduced effort, they are hypoxemic, they are going into a theater, they are going to undergo general anesthesia, all those are just going to worsen the pneumothorax if it's there, if you just close off this area here, okay? So what you need to do temporarily, put on a three-way dressing, and here they used it looks like what we call a warm blanket, okay? That reflecting material. But what we use, you can actually use just gauze, okay? Thick layers of gauze and just put strapping on 3 areas. So what you're trying to do is create a flap that can allow air to come out, but not allow it to go in, okay? So you're creating a one-way valve with your 3-way dressing.
Dr. Athieno, can I
Any
make-
addition to that? Yes, Dr. Kabweru.
Oh, thank you very much. These sucking chest wounds are very key. So the reason why we use that 3-way, what we call a 3-way strap wound closure, is not to allow air in anymore, to avoid the tension, build up of the air within the pleural space. So temporarily, we use it temporarily. And after doing that, you do 2 more procedures. After putting that, usually that flap allows air out, but it won't allow air in. And we expect that kind doctor there who is very enthusiastic and professional to put in a chest tube. That's the second. So after putting the chest tube, the third thing you're going to do is now to come to the wound primarily, and then you debride, and then you close primarily. And make sure you use full thickness closure and you don't end up with herniations. You know, there are people who breathe and then you see like that chest wall is going to balloon out. So please do those 3 things for me and I'll be very happy. Even when you do them to Alo and you call me, I'll clap for you. Thank you.
Thank you, Dr. Kabweru. Okay, moving on. The other issue is if a patient comes in, absolutely penetrating trauma, like that picture of these boys that are in here that came into the emergency department. Someone needs to mute. Okay. So when a patient comes in, sometimes they just come in with a wound, like the previous case we just discussed, but sometimes they actually come with an impaled object in situ, okay? And of course, sometimes it looks very distressing to the patient, the attendant, but also to the doctor. And the temptation usually is to just pull the object out, okay? So with an impaled object, absolutely leave the object in situ until you know how far it goes, okay? Because there are so many, as we saw in the chest cavity, in the thoracic cavity, there are so many organs in there, but also we saw the extension or the connection between the chest and the abdominal cavities, okay? In that, if you see this spear going through here, we don't know if it actually still within the chest, I mean the thoracic cavity, or it has already penetrated through the diaphragm and it's actually in the liver on the other side, okay? So if you just remove that and it has gone through some major blood vessels, your patient is going to bleed out on table there and actually exsanguinate and die, okay? So leave them in situ. If they are stable, you still have opportunity to go and investigate them fully, like these x-rays you're seeing and CT, okay? You're able to investigate them and see the extent, and I'm sure Dr. Kabweru will be very happy with you bringing in a patient and they're seeing where this object is. But if your patient is unstable, this is a patient who needs to have an emergency thoracotomy done. So you call in the CTS surgeons immediately, not later, not after you have investigations done, okay? And yeah, so that's what I'm saying. If there is time, the patient is stable, their vitals are okay, saturating well, the BPs are not crashing, you still have time to roll them to CT, investigate properly, and then take a patient to theater whom you actually know. But if there is no time, please, this is a patient who needs to go into theater immediately.
Can I make some contribution, doctor?
Yes, please.
Oh, so such patients, actually, they are the ones that we need to be very cautious. Since you are a doctor and you're not a specialist in pulling out things, one important thing that you should be very cautious. One, if someone has come with something going through the chest, you really don't know where it's going to end. One important key thing you should do, make sure, one, the patient is stable. ABC is very important. If this patient is losing a lot of blood, please make sure that this patient can access a CT angio, and we are an angiogram, and we are able to see whether there's any vascular injury or cardiac involvement. Sometimes you have myocardial contusion, and you need to set in and prepare for a cardiac repair. Or if it's vascular, you need to go in when you have your adequate vascular sets, so that you are able to repair the vessels that are involved, and you need to have the appropriate sutures, and you need to have the appropriate set. Otherwise, if you cannot achieve any control and you just specialize in pulling things, actually you may pull out somebody's life, and actually the next personal station will be the mortuary, and you shouldn't, that wouldn't be very nice for you. And then the other important thing is that if you're losing 100 mils within a drainage, for instance, if you are putting a chest tube, that you just need to know that there is a possibility of vascular injury. Or if you're draining 200 mils per hour, be prepared. Or the other thing, if your patient is decompensating, that's a patient actually you go and prepare for an emergent thoracotomy, and surely prepare to stand for some good hours. And you pack your abdomen also with some food, so that you don't collapse on the patient. Thank you.
And that's you, Dr. Kabweru, not these other doctors. Yeah, so Dr. Kabweru has really hinted on indications for an emergency thoracotomy. He has mentioned, of course, the other treatment measurements that I didn't mention, even with penetrating trauma, is you need to put in a chest tube if there is evidence of a hemothorax or pneumo, either on your assessment or with an EFAST, okay? So and the good thing with putting in a chest tube early is that you're able to actually monitor and see whether it's massive hemothorax that would require an emergency thoracotomy, or if it's stable and the patient can actually go for further studies. So Dr. Kabweru has just mentioned how you can monitor the amount of blood coming out of the chest tube per hour. And if it's more than 200 per hour, then you know that's actually active bleeding. So you need to go in early. And if it's a one-off of around 1,500, then you need to go in. Not you, but you call in the cardiothoracic, including Dr. Kabweru. So Dr. Kabweru, I'm also speaking on behalf of the majority of the healthcare providers here, where you don't normally have access to a CT angiography, okay? So what would you advise would be the course of action in such areas where absolutely there is no CT angiography, the patient is not stable enough to actually go through public transport or even on an ambulance to Mulago National Referral CTS ward? What would you advise?
Probably I can share some
yes.
example. I think 2 months ago we had a referral from Moroto. We have one of our senior doctors there actually had a bleeding aneurysm of the femoral. And this patient, she was a 46-year-old female, shot by an arrow, and then went home. And then after 2 weeks, I think the pseudo aneurysm gave way, started bleeding. So the good thing that surgeon assessed the patient and he called me, it was around 11 in the night. They mobilized an emergency ambulance, and the patient actually arrived the next day at around 10 in the morning. And we took the patient straight to theater, and we saved that patient's life. So I would encourage everybody to refer, timely referral. The good thing that we have EMS, and they have put regional referral ambulances, and they have their system, and you can call, and they have their toll-free numbers. Make sure that you work as a team. If you don't get all those, we call the commissioner in charge of emergency. Administrator, the Dr. JB will sort you out. You will get an ambulance from there, they deliver the patient. Even after working on the patient, they gave us the ambulance that took back the patient. That patient is still eating. whatever she's eating up there. So please refer in time, but don't wait don't do the delays. Sometimes decision making is delayed, and then you start telling people there's an ambulance. There's an ambulance if you call the right person. Or you call the MPs in that place and you say they give you and fill the ambulance until the patient can reach Mulago. So you, as you're a doctor, find your social responsibility to the community that you are failed, not because you're a doctor, you only failed by saving lives. So make sure you go out of your normal small box and think around for resources and make sure that patient is received at the next. But you communicate. I thank Dr. Rukundo, is a consultant general surgeon in Moroto. He called and we also prepared. Also, I communicated to my team in Mulaga, and they are aware. We had other patients, but that patient was already on our list. And surely that's how we managed to save. So we can even save these patients when there's that constant flow of information. Don't even hesitate to call even in the night. As doctors, you know, we work a day and night and there is no holiday, even weekend, and public holiday. Thank you.
Thank you, Dr. Kabweru, for that. I think you really hinted on some key aspects, especially the multidisciplinary approach and not working in silos. Okay, so if you have a patient like this and you're in a facility that is not capable,
Is there a network? Hello?
Dr. Justine, are you there? Dr. Justine, can you hear us?
He's on strike.
I think we got a network challenge. Probably when she's back, she will join us very soon. So, Dr. Justine, can you hear us? Okay, it's on this point that without wasting time, we can go to cardiothoracic surgical management, which will be taken over by Dr. Kabweru Wilberforce. Doctor, you're welcome.
Thank you. I'll just continue where she has stopped. You can put up my slides and I just go through. Dr. Justine, when you're back, you let us know and then we continue. Oh, Dr. Ibrahim, you. Okay, can we move to the next slide? We had chatted a number of things. Let us continue down. We continue.
Oh, yeah.
Continue. 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 Those are just some of the examples. Yeah, I think that slide is very key, the epidemiology of chest trauma. Actually, chest trauma is the third most common cause of mortality globally, following head and abdominal injuries. So you see that actually it causes a lot of death. So you shouldn't take it for granted. And the 80% are blunt chest trauma. Then we know that actually most of these can be managed conservatively, around 60%, and the 20% or 15 to 20% may need surgical intervention. But also we know that 25% is the commonest cause of overall mortality, including other malignancies and other infections. And the majority of these are preventable death. So we shouldn't leave somebody to die of a chest injury and you say you cannot do anything. Please, you can do a lot of things. And we have already said that less than 10% of the blunt chest trauma require surgical intervention. So that means you can manage them conservatively, but you need to investigate and know what you're managing. Compared to the 30% of those that have penetrating injuries. You can proceed. We can jump that and proceed. That's the ABC. Now we are actually, we cannot, the most important points from that slide are that the moment you get a patient with a chest injuries, please make sure that you give 100% oxygen. Why? Because hypoxemia is one of the most poor prognostic factor that actually will take your patient when it's not sorted out. And secondly, I was talking about shock, and it can lead you to excessive blood losses from either vascular disruption, like aortic disruption, or cardiac tamponade, or myocardial contusion. And these have been, and we know that actually 80% of patients who have myocardial contusion, actually aortic disruption, don't reach hospital. They disappear in the pre-hospital arena. But also, when you have poor pain control, it's also a very big challenge, especially if you have blood chest injuries, because those shallow breath cannot enable the lung to expand, and the patient actually ends up with a poor pulmonary toilet and eventually with pneumonias. So if you would sort out blood chest injuries, by the oxygen, make sure you have controlled pain. Antibiotics may come later, but it's also very key to sort out the saturation, that is blood. If people have lost a lot of blood, we can go to another slide. We had talked about even number. Yeah, I can. Okay, so we welcome back Dr. Justine. Let her continue our oral supplement. Thank you.
Sorry,
from where I stopped.
Thank you. The Ugandan network happened, but I'm happy that I'm back.
Yeah,
so
can we also happy to have you. And since ladies are over, the gentlemen are under the ladies, so we shall continue.
Okay, Thomas, can you? Okay, I think I can now share. Yeah, so I was still talking about the potentially life-threatening, like they will not kill the patient immediately, but if not addressed, then they can actually lead to death. Okay. I saw Dr. Kabweru had already mentioned some of the other issues that we might talk about also in the C. But let me first talk about the flail segment. So this is where you have two or more ribs that are broken in two areas. So you have a segment in between that is really not connected to the rest of the rib cage. And so with every breath for it, it's doing the opposite of what the rest of the rib cage is doing, okay? So this, normally the problem with this one is that it reduces that lung expansion around that area, but it also predisposes the lung to lung contusions, okay? They're usually associated lung contusion. Besides that, there's a lot of pain. So patients, the ones who are breathing, later on will actually stop. There will be what we call splinting. They will not nicely expand the chest because of that extreme pain whenever they move the chest cavity. So the biggest thing for us to do in the emergency department, or when you're faced with this patient, make sure their pain is controlled. So here you can either use regional blocks if you're in a setting where you have anesthesiologists or even EM physicians who can actually give you those blocks. If you're not, you should be in touch with, you should be able to access opioids. So these are patients that you give opioids every 4 hours and assess their pain control, because that alone can actually help improve their respiratory function. Okay, of course, that's on top of the oxygen and all the rest of the things that we do, positioning the patient, things like that. The other aspect that also helps with the respiratory function is what we call incentive spirometry. In our setting, I'm going to say this, of course, Dr. Kabweru is going to tell me how much perhaps this costs, but most of the times our patients are not able to afford that, or it's not available in most of the hospitals.
So what people are normally given this bag, like a plastic bag, and you tell them to blow in and out. So you're encouraging them to actually expand their lung with that. The other issue is if they are not able to do that, the pain is too much, they are frail, old. The other thing we go to is try to give continuous positive airway pressure. And this is using either a BiPAP machine or CPAP machine, if you have it in your hospital. And if that is still failing, especially in the frail elderly patients, frail I mean, you will need to actually intubate these patients and ventilate them for some time to until they heal and they're able to take over their respiration. There are some things that are normally done, like there is taping around the area of the flail segment. I'm sure Dr. Kabweru is going to comment on that and tell us whether it helps, or because some studies show that it actually instead increases the pressure that is around that area and actually doesn't improve ventilation in that lung. So I would like to invite Dr. Kabweru to comment on management of flail segment. We had already commented on subcutaneous emphysema management, so we won't go there.
Oh, thank you very much, Dr. Justine. I would first of all say it depends where this frail segment is located. Now, it is always very important to immobilize a fracture. So I'm going to say that if your frail chest is actually posteriorly or underneath the scapula, that bone behind your shoulder, that scapula is going to be like the splinting. So what you need to do is to control the pain properly and make sure that actually the patient is well controlled, and you give the disincentive spirometry. They are cheap these days. They are between 40,000 and 100,000, and they are available on the market, both adult and pediatrics. So I would discourage the use of balloons. Balloons actually cause lung collapse, and they will not do us anything better. But when you have this, it has directions you use, and then it will make your lung expand, even expel the X-ray that is in the pleural space, and the lung will expand, and the patient also will be doing aggressive chest physio. So it will help here a lot. Now, if the rib cage, or if the frail chest is anteriorly, and this patient is not in respiratory distress, you may need to put on your dressings and make sure that you can even use a brace, and you make sure that the patient is comfortable. But then if it interferes with your respiration and this patient starts desaturating and you've given oxygen and it's not stable, you may need to splint that frail chest or frail chest. So sometimes you may need to open, the splits wires that you pass along the segment so that you stabilize it, and they will stay there for a long time. Other people actually, if they have the money and they can afford the plates, we can put the plates, but you see they are very expensive. One plate can go for around 750 onwards. So if you can't afford, I always say, if you can't afford, avoid trouble, avoid getting chest injury as much as you can. So I would advise that actually we take care of ourselves and we make sure that we are not in big trouble. But in case you get that frail chest, please manage it very well. Otherwise, the complications are quite a number, and when they set in, really, they will cause for more surgeries to come later on, which we are trying to avoid. Thank you.
Thank you, Dr. Kabweru. We shall carry on. The other ones we had already really mentioned about them. These are simple pneumothoraces or hemothoraces. So these are the ones that are not massive, where you still have time to do an X-ray, get to know how huge it is. Someone needs to mute. And then put your chest tube properly. There are issues if you do your X-ray and you see a very small pneumothorax, there is room for you to just aspirate it, but this has to be really decided by a senior person, not just an intern doctor, because I mean, there are so many factors that are involved in just aspirating a small pneumothorax that is due to trauma. Especially now where you're really not monitoring people properly, you just leave them in the night, you find this patient dead in the morning. So Dr. Kabweru is smiling. I'm sure he has a comment on this one.
I was going to ask Dr. Justine, since you can estimate how small it should be that small pneumothorax. It is a very difficult question, but it depends on patient per patient. But there are so many people who are moving with their pneumothoraxes around town and they are stable. But when there are chances that actually it will expand, or if it has recurred, and one time you had a chest tubing and then it's recurring, sometimes we need to look for the definitive problem. Or for those patients who have what we call blast lung disease or polyps, then we need sometimes to do segmentectomies. So we go in there. Lung disease, or we can end up doing a lobectomy, or if one lobe is already heavily involved, or if it's a whole lung, then we end up with a pneumonectomy. But you should avoid to go to those extents. Those are patients should be followed up cautiously with the serious chest X-rays and then see whether the lung is not collapsing. That is very important to know. Thank you.
Okay, thank you, Dr. Kabweru, for those comments. We are almost getting there. I don't know if I should just continue or we should be answering a few questions about where we've reached.
I think you continue. You can continue.
We continue.
And we answer most of the questions.
Okay, right. So the next issue in the assessment is assessing your circulation. Of course, the same thing applies, okay? What you've already been taught about assessing circulation, doing your pulse, checking for peripheral saturation with the capillary fill time, the volume, the characteristic of your pulse, your blood pressure, checking the jugular veins, and then listening to the heart, okay? So the life-threatening issue here, normally the problem we find with patients with chest trauma is shock, and mostly it can be either obstructive, but at times it can actually be cardiogenic, okay? We had already talked about tension pneumothorax giving us obstructive shock in chest trauma patients, but the other key issue is cardiac tamponade, okay? It's quite common in penetrating chest trauma where the object just goes and directly injures the ventricle or one of those major blood vessels, and then you have accumulation of blood around the heart within the pericardial sac, like you're seeing here. And when that blood, especially traumatic pericardial collections, usually accumulate very fast if it's a huge, if it's like penetrate.
You don't need to prove anything to her. She loves you.
Someone needs to okay. Yeah, I was talking about how unlike where we talk about where we have accumulation of fluid around the heart in these chronic conditions like TB, where it takes quite a long time for you to actually get a tamponade. With a traumatic pericardial tamponade, you get rapid accumulation of fluid around the heart, which constricts its venous return, but also in the end reduces the cardiac output, okay? So it's important to remember this Beck's triad, where you have the distended jugular veins, you have the low blood pressure, and then you have muffled or distant heart sounds. But it's also important for you to know that these three are not always there. So if you have a patient who has penetrating trauma, they are in shock and their jugular venous pressures are high, but their chest is okay, there is no tension pneumothorax, suspect a cardiac tamponade, okay? And if in a setting where you have ultrasonography, you can actually do a bedside ultrasound scan, what you call an EFAS, that just looks at the heart and the surrounding surface. And if you're to see, the blood around the heart will look hypoechoic or dark, as opposed to the heart muscle, that is just adjacent. So if you see that, that is confirmation, and the management is a pericardiocentesis. So if you have an EM person there, like myself in your center, those are the guys that can actually put for you that emergency, do for you an emergency pericardiocentesis that I'm showing here in this other corner here. The move now is from blind pericardiocentesis to ultrasound guided, because the success rates are very high, but also the complications of lung injury are low. So if you have ultrasonography, absolutely do this. Most of the times, these patients might actually need a window, or they might actually need assessment to know what is actually causing this. So early on, calling in the CTS team is absolutely important. I can't see the panels, the rest of the panels video, so I'm not sure if you guys are still there. Can you hear us?
Yes.
Yes, Dr. Kabweru. Yes,
Loud
I wanted you
and
to
clear.
comment. Yes, to comment on the. Yes, please.
Yes, we are hearing well.
So acute cardiac tamponade is one of the most life-threatening conditions if it happens, and actually it may be confused with the tension pneumothorax, but they are very simple things to differentiate. In tension pneumothorax, when you listen, there's no breath sounds on both hemithoraxes, whereas here you have both on both bilaterally. There's good air entry. But then when you go on to look at the res jugular, in both there's res jugular venous pressure. And then, but what will differentiate with the cardiac tamponade is that the BP sometimes is very low. And then you have distant heart sounds. And how you do, you can decide to do either an emergency pericardiocentesis via subcutaneous, that is through below the visternum and ultrasound guided, and then you go at 45 degrees towards the left shoulder tip, but under guidance of the ultrasound scan, what we call image guided. And you avoiding injury both to the heart and to the lungs. So, and sometimes if you injure the lung, then you may need to live in a chest tube at the end of the day. That's why you continuously monitor where your cardiac is passing. But then, if you have opened up this patient at thoracotomy, emergent thoracotomy, it is even easier, because you are going to do a pericardial window, and then you live in your chest tube, that pericardial sac, to drain out more blood. And if there's a laceration also, especially if it's the right ventricle, which is anterior, then you repair at the same sitting, and you leave the patient doing very well, and you actually exteriorize the chest tube, and then you remove it later when the drainage is 0 or less than 50 mL of serous fluid. Thank you.
Thank you, Dr. Kabweru. We shall move on. We had already talked about this tension pneumo, so we shall move on. The other aspect that I talked about is the cardiogenic aspect, especially in patients that are coming in with blunt chest trauma, but with this kind of mechanism, okay? If a patient comes in and they have sternal fractures, okay, fractures to the sternum, bruising around there, the mechanism speaks to, for instance, a steering wheel mechanism, then the likelihood that they actually got cardiac contusions is very high. So these are patients that you need to actually, you know, in the circulation part where I always say hook the patient on the monitor, even in a trauma patient, you absolutely need to know the rhythm that they are in, you know, because sometimes with that trauma, with that direct impact, you can actually stimulate life-threatening arrhythmias, which cause sudden death, and that's called commercial codis. It's normally seen in like sports injuries, but it's not rare also in trauma patients. But these are patients that might not come to the ED. If they come in, they're probably in a cardiac arrest, and you find them either already in a systole or they are in a shockable rhythm. Okay. The other aspect is the cardiac contusion. So the cardiac output will not be as adequate. The myocardium will not be, there might be issues with the squeeze. So these are patients you really need to do an ultrasound scan and check and see about whether they would need some vasopressors, but also ionotropes on board. Yes. On this particular injury, Dr. Kabweru?
Yeah, no, thank you very much. I had already read the treat a little bit, but injury to the cardiac tissue can cause a lot of arrhythmia and a cardiac arrest, but they are more common in blunt chest trauma, especially which is intense. So when you get any injury to the sternum, or injury to the first rib, or injury to the scapula, that is extensive. And those three I've mentioned are usually associated with vascular injuries. So for this cardiac contusion, you may need actually to go in and repair the heart and also leave in a drain so that you can drain out the pericardial fluid. Because if you don't do that, then most likely the fluid that will accumulate around the heart won't allow the heart to continue pumping normally, and you end up compromising the saturation. But it is paramount for you to access a CT, angio, and the ECG. And that is very important. And usually you will be very lucky, especially if the right ventricle, which is anterior, is injured. It's good repair and you'll go away without any issues. The challenge comes in when you have the right atrium injured. It has a very thin layer, and those are patients actually who lose very fast. If it's the left ventricle is hidden the other side, you have some work to do, and actually you have a run of your money and your skills, and that day you may not just take it for granted. But also, alongside this, you need to rule out aortic injury, because this is also very common, and these patients, if I was in A center 1, A center 2, 3, 4, up to 5, 6, before you go to the national referral, I would just plan to stabilize the patient as much as I can, and I refer where they can open and repair the heart. Thank you.
Thank you, Dr. Kabweru. Yeah, so the rest is really just going through. So in disability, these patients, because we've talked about the mechanisms, so it's not rare that they come in with polytrauma, and the case that Dr. Najemba just talked about actually came in with other associated injuries, fracture humerus and whatnot. So head injury might not be that rare. So make sure you assess your patient as you normally do in the primary survey. And if they have any reduced level of consciousness, which in chest trauma might actually come from shock, okay, hemorrhagic shock, obstructive shock, like we mentioned, but also they might be severely hypoxic, okay? So that Glasgow Coma score is quite important for you to score initially as you're managing, and then rule out any other associated head injuries. Then with exposure, it's important for you to look at the back of the patient. With very sick patients that you're trying to put in a chest tube, there is this other bruise here, you think it's a hemo, you forget to actually turn them and look at the back, but there might be an open wound there, a sucking wound that you're not even taking care of. So absolutely do not forget to look at the back of the patient in your exposure. And then I'm summarizing Dr. Kabweru, and then you'll come in with final comments. Is that okay? Okay. Yeah, so investigations, they really cut across, but for these guys, it's important. I did not mention things like diaphragmatic injuries that sometimes are very, very tricky to diagnose in the acute phase. But later on, like this patient who is coming in after they had gotten chest trauma like 2 months ago, Dr. Najemba's patient, 2 months ago, and they are coming in with chest symptoms. You need to think about things like diaphragmatic injuries. But investigations are quite important in such patients to diagnose things like that. So a chest X-ray, a chest CT scan, if they can do. If you're thinking about cardiac contusions and whatnot, cardiac troponins might be very, very helpful. But also, if your patient is having arrhythmias, it's important for you to know if they don't have any electrolyte abnormalities, because then they make that already damaged, injured cardiac muscle to get super excitable. Then you can actually lose your patients to just the arrhythmias. Then, because you're talking about blood vessels, major blood vessels, it's important for you to check the coagulation profile of these guys, because if they are not clotting, okay, then if the aorta is dissecting, okay, or ruptured, as Dr. Kabweru goes in, he'll just flood in blood. You know, the entire table will just be full of blood and work will not be done. So make sure you get their coagulation profile and address any other derangements that are found therein. ABGs are important because we've mentioned some issues that are to do with the lung tissue itself, but we've also mentioned things that are going to prevent the expansion of the lungs and end up giving us things like type 2 respiratory failure. So ABGs are quite important. They really inform you a lot in the acute management of such patients. And I think we've already mentioned these guys are going to be in Dr. Kabweru's ward. But if they are very unstable, they will need to be in an intensive care unit where they are monitored very well, and they're actually ventilated. There is organ support if there is need. And depending on the injuries that the patient has, you might need to involve the cardiothoracic team, you might need to involve the general surgeons or GI specialists, depending on what you have. And I will rest my case there and invite Dr. Kabweru to complement with some comments before we go into the Q&A session. Thank you.
Thank you, Dr. Justine, for the good presentation. It was really interesting because you really highlighted the detailed ABCDE examination approach, and I think most professionals have really gained from your elaboration. Thank you very much. Now we welcome Dr. Kabweru once again for the cardiothoracic surgical management.
Thank you very much. We have been managing together with the emergency physician and the whole team. So my comments are going to be few. One, let us learn to take history. History taking is key. Physical examination following the IPPA, that is inspection, palpation, percussion, auscultation is key to the chest. And if you don't know, ask. Don't keep quiet and we lose the patients. Imaging. I know the emergency medical team trains people on e-first. Please train everybody, including the hospital directors and all the not alone the surgeons, but everybody in the hospital, including the askari, can be very important, can save a life. And then obviously, yeah, chest X-ray is very, very important. People need to know how to read a chest X-ray. And the lungs, you know, they carry air. So if you're seeing something that is not air containing and not air, then you have to emergency jump in. If you don't know how to read a chest X-ray, please learn. If you find a widened mediastinum, suspect there is a vesicular injury or cardiac lesion. And it is important for you to know what investigations to ask. And the chest X-ray, if not so available, please try and do the scanning at whatever level. The good thing that we have scans even at 10-3, according to the so what is it called this day? This new model, what is it called? The Paris model something? So we expect the ultrasound scan to be there. But at least all the regional referrals have chest CT scans. So I'm comfortable that whoever gets an injury can get a chest CT done. And if patients can't afford, please waiver, and these patients get free services since these are public hospitals. And if they can afford, and your public service hospitals are down on the city, please let them afford from any emergency facility that is available, whether private or private, not for profit, and diagnose and help. Even when you are called out of your office, please go and help this patient. Whether another mango tree or something, save a life, and then we can always manage the complications later. I'll end it there since we have been managing together for the Q&A. Time is running and rushing. Over to you, Cleophas.
Thank you, Doctor. Thank you very much, Dr. Justine and Dr. Kabweru, for the amazing and interesting session. So before we go to the Q&A, we have the ICU nursing care. We need to go to that because it is very paramount. Because before we discharge the patient has to be stable from the ICU. So it's on this point that I invite Mr. Osire John Andrew to take us through the ICU nursing care that these patients really need once they are from the ED. And then we see how we can go to the Q&A after that. Thank you very much. Over to you, Mr. Andrew.
Thank you so much, Cleophas. Yes, we are receiving our patients in the ICU, stabilize them, connect all the vital gadgets. Some people call them wires. Make sure you're connecting your SpO2. This patient has sustained a chest trauma. So what is our chest giving us? We need to know the oxygen levels, need a temperature probe underneath the armpits. We're going to put our ECG electrodes so that we can be able to read and know the trends in the ECG. And then end tidal if the patient is going to be ventilated. So we need our patient in a sitting position, cardiac, for oxygenation, and we are going to supplement this patient with oxygen. Now, as I said earlier, we may do nasoprongs depending on how the sats are and the distress. So remember that the patient has a underwater seal drain. So we want to look at patency. How patent is the water seal? Is it draining? Patency. So there's what we call tidalling. Tidalling is where we want to see the liquid moving, the liquid within the tube. Oscillation of the liquid from the patient and the tube. It should be moving at the same time with the respirations of the patient. It should move until when we are certain that the lung has expanded. Next, as a nurse in the ICU, you must be concerned about the amount. The amount that is in the underwater seal. How much is there before your shift? Label it, write the date, the time, and your initials. So that by the end of your shift, you are able to appreciate and know that the drained fluid liquid has increased by this much. If it increases over 100 mils within an hour, please call the intensivist, the doctor attending, whom you're working with on call, and notify the doctors. Also, with the doctors, Dr. Kabweru may need to know a change in the color of the drained fluid. We need to take note of the color that is in the underwater seal. In case it changes during my shift, I should be able to notify the cardiologist, my CT surgeon, or the intensivist that change in color. Should be able to label. I've said, mark, you label initials, the date, the time. Then a kink, make sure your underwater seal is not kinked. There shouldn't be anything like a kink like this. So otherwise we will make it worse, ending up with what did we call this? A tamponade. So make sure all the tubings are aligned straight, direct from the chest into the receiving drain bottom. So the other thing with kinking, we should make sure the tubes are not so long enough that they are dragging underneath, that they are going below or running below the receiving point of the bottom. So make sure everything is above to enable gravity to take its course and aid with a draining. We also need to do what we call milking. Milking is to make sure that patency, we want to see, when we milk, we want to make sure there is nothing. There is no clot, nothing is hindering the flow of the tidally, of the fluid moving in sync with our respirations. So normally we encourage, you can use any soluble, any water soluble substance, any gel that you can enable you can apply it, run through the tubings. One hand should hold, another one should continue to milk down towards the drainage. So check also as a nice CCU nurse, is my patient in distress? Are they cyanosed? Are they oversweating? How is my patient presenting? Don't override, don't forget, do RBS. Know what sugar levels your patient is at, and also so that you can flow and be in sync with your doctor or the intensivist on call. In continued management in the ICU, 2 hourly, always encourage this patient to have deep breath. After every 2 hourly, at least two, let him or her take, since it's a KH, let him take 2 deep breaths within the 2 hours to aid and give more expansion of the lung to prevent collapsing. Also, within these 2 hours, nursing care, we need to encourage the patient to change from one position to another to enable drainage to be effective and also to prevent other complications that may come on board. Osculating nurses, we do not want to osculate, but I would encourage, the more you osculate, the more you improve on your skill of listening. You may be able to listen to various sounds, crackles, crepitations, and you are the ear and the mouthpiece of the doctor. So tell them what sounds you are hearing. Are the sounds balanced? Are they unequal? Or how is the air entering in the lungs? If the patient is ventilated, communicate so that we can know whether to reduce the PEEP or whatever we have to reduce that's likely to cause bowel trauma in this patient. Placement of the bottle, make sure the underwater seal is, as its name is, under. It should be under, not at the same level with the chest where the tube is running for. Make sure it is under or at a special place where it is held. In the Western world, they have special places where the bottles are placed. Also, take note of the site of the insertion of the tube. Why do we need to take note? We want to check whether infections, is the place infected? Is it septic? We have been talking about subcutaneous emphysema. We want to confirm, to prove, is it there or not? Among others also, I do want to end with this, as the tube shifted, is it displaced? Has it left its position? So we need to take mark of the site of the placement of insertion, of the place of insertion. Always let us, as nurses, we should not also leave the passive range of motion only to the physiotherapist, but let us encourage them to move the other limbs that could be affected, just to also aid and encourage the affected limbs to move for better mobility, or they may become contracted and pain may intensify when they try to move it. Yes. When they are moving, in case of any transportation, always clamp. That is why always on the bedside, we should have a special trolley and a kidney dish with clamps for this. Any movement, anything they want to do, please clamp. And also, when the tubes are long and they are hanging, try to clamp them on the clothing of the patient alongside the clothing. You clamp them so that they don't go below the expected size and cause a backflow of the fluid back into the lungs. Spirometry, Dr. Kabweru has just said we are discouraging balloon blowing, which can instead worsen the condition of the patient. So we need to avoid that. Pain management, that's a must. We normally give, depending on what medication will be, morphine, in ICU, maybe fentanyl, infusion depending, but on small doses, since most of them tend to be conscious and we don't want to suppress their respiratory centers. Yes, anxiety, we also have to talk and encourage these patients to keep calm, and reassure them that they are going to overcome this state. For now, that's all I can wrap it up. We shall add more in the Q&A. Thank you so much.
Thank you very much, Mr.
John.
Okay. Thank you, Mr. John. We are going to, before we go to the Q&A, I would like to recognize Dr. Pande, who is the director of Moroto Regional Referral Hospital. Dr. Pande, maybe you can give a comment, because we see you did a very great job in the referral you did the last time. If you're online and on the call.
Yeah, thank you very much, Doctor. Thank you so much for organizing this very, very important meeting. Apologies, I joined in a bit late because I had another meeting to do with the budget framework paper. I want first of all to really inform you that emergency medical services is the thing more so for us in Karamoja. You know, Karamoja is a place which is unique in a way that it has so many natural calamities and humanitarian crises. So this all call for emergency kind of response, emergency kind of care. So for us as Moroto Regional Forest Administration and Management, we are fully in support of this and want to save everything to support the emergency medical services. However, I want to say this, that yes, we have trained ICU staff. We have some equipment to kick off, but as you know, our infrastructure is a challenge. The challenge now is that we don't have enough space for service delivery. And as if many of you may be knowing, Moroto, most of the structures, they are dilapidated and they are overdue. They are condemned. So I don't know, I'm just thinking aloud, if there is a way, maybe you can guide us, maybe by all proposal, concept writing, so that we can have at least some, because we can prevent a lot of preventable deaths in that region. So I want to thank you so much for the opportunity to give me, but to give in a word or two, I thank you so much.
Thank you very much, Dr. Pande. I want also to recognize Dr. Mary Ellen, an emergency medicine physician, Mulago National Referral Hospital. She has really answered a number of good questions in the chat. Thank you very much, Doctor. So now, before we go to the Q&A session, I would like to emphasize on these things. Please, in pre-hospital, people endeavor to remember the three-sided dressings and the people in hospitals, because this is a single valve, doesn't let air in, only lets air out. Then after that, you need to insert a chest tube in time. Then timely referral, then you need to do a multidisciplinary action. This will be helpful in the treatment of our patients and saving lives. So now, let's go to the post-test. And as we go to the post-test, we'll be giving answers to the Q&A. Now let's begin with Natkunda Sylvia's question. She was asking, what causes tracheal shift in tension pneumothorax? Dr. Kabweru.
Tracheal shift? It is not only in tension pneumothorax that we have a tracheal shift, but some of the causes. One, if it is tension pneumothorax, the shift will be towards the opposite side. That is normal, because the tension will push it towards the other side. But also we have other conditions where we have a tracheal shift. For instance, if you have lung fibrosis, actually it will collapse toward, it will be shifted towards where there is a fibrosis. So it is just indicating that actually there is a mediastinal shift. There's something that is pushing the mediastinum to the opposite side. Now, also when you have extensive subcutaneous emphysema and it causes a mediastinal shift, you have a tracheal shift and you need to actually deal with that. Now, the challenges with these mediastinal shifts is that they compromise cardiac output and don't just look at it and start dancing or start singing, start appreciating, or start saying, oh, this is a good patient with the mediastinal, the tracheal shift. Please sort out the problem so that at the end of the day, the patient's life is saved. Dr. Justine? Yes.
Yeah, you've done a good job, I think. Let's move on to the next.
Okay. Then the next question is, what do you consider when you remove a chest tube? I think this one will go to Mr. Osire. What do you consider to remove the chest tube?
Thank you so much. Yes, as I've said, number one, this chest tube should not be infected. With the sepsis on board, we should have resolved it. And then the main reason, the main indication of the insertion of the tube should have been resolved. That is the main reason as to why we want to now think of removing. Has our lung expanded? Is it back to its normal function? Yes. Now, as a team, we now may consider to have that tube out of place. Thank you so much.
Can I just add? Yes. Thank you very much, Mr. Osire. So one of the most important things, first of all, most people don't want chest tubes. They are very good, but they also have a lot of mobility and mortality issues. And I was actually looking at this patient who had a chest tube for 10 days, quite very long, especially if it's in the trauma, chest injuries. Why did you put the chest tube? Is the question you're asking. And when should it be out? One, if, for instance, there's any pleural collection and you usually monitor every 24 hours, how much are we collecting? And if you look at the color of what you're collecting, also depends on what you want to empty. If it's there and it's out and the lung has expanded, please remove the chest tube as soon as you can. If you're draining blood, you shouldn't want any single drop of blood remaining there. But also, as you drain, as the days go by, usually that effluent changes color, and you want to remove it when it is serious, when it is clear or straw colored or pale yellow. And the amount should be less than 50 mils if it's pale yellow, because we assume that that one will be reabsorbed. But also, if you have a lot of effluent, or if the effluent is recurrent like in other conditions, then you have to get a permanent solution. Before you remove it, you have to pour days to seal that space between the palate and the visceral pleura. But if it's just trauma, just make sure the volumes are not there, you don't have any effluent in the last 24 hours. But also, we do a clinical check. Listen for breath sounds, and then do a radiological check. If you have a check X-ray, it's the best. And it will show you how your lung has expanded, how your pleural space is very okay, there's no collection. And then you check out this stubborn chest tube out, and you leave somebody to be not be under arrest in the bed or whatsoever in the hospital, and he goes home to rest and enjoy his days.
Thank you, doctor. There's another question which says, is it okay? What is the principle of underwater seal drainage? I think this one was answered.
The principle? What is underwater seal? I want people to know, when you put that tube in the fluid, there's what we call initial level. So that small column of water is what we call the seal. Above here, that's where the atmospheric pressure is acting to make sure that whatever you're emptying gets out, but there's nothing that is going into the lung, the pleural space mainly. And we are trying to maintain that negative pressure. And that's why we should not put too much column of water in that tube. When you put too much, it won't empty because it causes a lot of resistance. So it should be adequate. That's why those special bottles I was insisting, they should be used because they have initial level, and that column is very small standard. That's what they call the underwater seal. The other is the bottle, but that is the seal. Thank you.
Welcome. Then is CPR possible in chest injury? Mr. Ntege William, maybe Dr. Justine can.
You can give us your technique and your experience.
Yeah, thank you very much for that question, Ntege. Chest injury is like any other trauma, and CPR should be attempted whenever you think there is a reversible cause, okay? So, of course, when it comes to outcomes, and what you actually do during the CPR is quite different when it comes to chest injury. For instance, if you have penetrating chest trauma and you get a cardiac arrest, these are patients that you want to consider to do an emergency thoracotomy while they are doing it. Like you want to do open chest CPR because you know there might be buildup of fluid around the chest, I mean around the cardiac, around the heart. So you want to open up and actually do, and it's, of course, the success rates are not as nice, but it's always good to try. We all know that cardiac arrest in trauma, their outcomes are far less than a cardiac arrest elsewhere. So the best thing you want to do is to avoid your patient with chest injury getting a cardiac arrest. The approach is the same. CPR, if it's a shockable rhythm, shock. If it's non-shockable, give epi. If it's penetrating trauma, think about doing an emergency thoracotomy in the resuscitation bay. Thank you.
Thank you, Dr. Justine. Here is one more maybe for you. They say, is it okay to reduce on the length of an impaled object?
I think, thanks for that question, Sharon. So it's, I think you guys probably have watched some movies where a patient is actually held up, they've been pinned to the wall by this object, a pipe that is going through their chest. So if you can stabilize that object, and if your management really depends, will be affected by this very long object, it's actually imperative that you reduce the length if you have the gadgets. If you don't have the gadgets, my dear, the best thing for you to do is just take this patient to Dr. Kabweru. They handle from theater after they've prepared. So yeah, that's my answer to that. Thanks. Yeah.
Thank you, doctor. Then Abdul Hussein Mohamud is asking the highlights on the size of the chest tube based on the patient's age. The highlights on the size of the chest tube based on the patient's age.
Oh, if they are babies actually. Oh, I was speaking about adults, about 50 to 75. But if they are babies, it shouldn't be longer than 25 centimeters. Or if the baby is on the bed, then it should be just below the bed, longest on the floor. But also there are those rails that usually where we put. When you make it longer, that column of air is going to obstruct drainage. That's the principle. That column of air will obstruct drainage and you won't achieve why you put the chest tube. So don't make it very long. Keep reducing it until it's appropriate for age. Thank you.
Thank you very much. You have a supplement? Okay. Then in a patient with frail chest, should we be scared of respiratory depression considering the effects of opioids? I think Mr. Osire explained about how to use the dose of opioids in ICU and in these patients. Then Tukunda Sylvia asks, should systolic BP kept low in a chest trauma to reduce blood loss?
I think I needed to comment on one condition where we need to be cautious about fluid resuscitation. That is the pulmonary contusion. It is not, we are not worried about the lesion itself or the injury, but we are worried about the edema that comes. Because should you give a lot of fluid and you worsen the edema, it will be very difficult. As I'm saying, very difficult. If you're in Mulago, the only station will be 1D. 1D is the mortuary. But otherwise, if you want to maintain your patient on other ones and you want the patient to leave Osire's ICU so that he comes to 2B CTS, then better to be cautious about what fluids. And we usually recommend colloids, but make sure the patient is volumic, normal volumes. Don't struggle to make sure that you overzealously infuse this patient. Otherwise, if your patient is stable, apart from those conditions where we said if there is hemodynamic instability, please manage other things and don't worry about them. The patient can drink in most cases, unless if you have an esophageal disruption, where we have to divert the feeding for orally and then we use other means, but better the patient continue drinking normally as you continue attending to the other factors.
Thank you, Doctor.
Okay, I will also add to this question because Sylvia is asking about hypotensive resuscitation. So it's called hypotensive resuscitation, not hypotensive emergency. The other word is resuscitative hypotension. So like you mentioned, Sylvia, it's usually used in blunt abdominal trauma, or if you're in an area and you have this exsanguinating wound on the extremities, and you haven't yet gotten to a theater where you can actually definitively either amputate or close off the bleeders. So it's part of the components of damage control resuscitation. So yes, the BPs are usually kept below 90 and for some patients below 80, but it's a temporizing measure. And I haven't seen studies about it specifically being helpful in chest trauma. Thank you.
Then the last question is about what is the position to press the patient while doing a referral? This one was asked by Dr. Luruki.
Dr. Athieno, which referral?
Yes. I'm not sure.
I think it depends maybe on the injury as.
Yes, so can you guys hear me?
The patient has a chest tube.
Yes.
Now I think I should cautiously tell my friends, because this happens a lot. When Osire discharges patients from ICU to my ward, they just leave that bottle to collapse. And then by the time the patient is on my ward, instead of the fluid, he has both fluid and pneumo, again here in. So the best we clamp. We use an arterial and clamp, and then during transit, anything can happen. So when you reach the other side, first is make sure the bottle is standing in position, and then there's that column of fluid in there, and then restart the tube again. So clamp, clamp, and clamp, and clamp.
Yeah, the other aspect I wanted to add, actually, I thought it's for this pre-hospital care provider
Yes.
who has gotten this patient with chest trauma and they know it's on that side, it's on one side. So the best thing to do, if you haven't placed in a chest tube, you just put your perhaps three-way dressing if it's an open chest injury, is to let them lie on that side so that you optimize ventilation with this other nice normal lung. So I think that's the other bit I would add in for pre-hospital management.
What about if you have tension pneumothorax and you put a needle thoracostomy? You may use the same principle. Lie on the same side and leave the other to function. But I encourage people to learn to put a chest tube. It's a 1 minute thing.
Yes.
Thank you very much, Dr. Kabweru and Dr. Justine and Mr. Osire. I think this brings us to the end of the discussion, the question and answer discussion. So next we go to the post-test, which most of us have submitted, I think, and we'll have the closing remarks. We begin with Mr. Osire, which closes the closing remarks of the session. How was the session, and maybe the guiding remarks you can give to the people listening in and seeing.
Thank you so much, everyone, for attending. Thank you, Seed Global, for making this reach different parts of the country. I saw someone post, I think was in Nigeria. Yeah, thank you so much. And even the grassroots, I saw someone go up to Moroto. Where was it, Doctor? Moroto. So I believe we have learned a lot. And as Dr. Kabweru said, we should just avoid chest injury. Any chest injury, please avoid, because it will cost and cost. Thank you, and I'm glad to be part of this. Thank you.
Dr. Justine, do you have any closing remarks?
Yes, thank you very much, everybody. I think this was a very interactive group. Of course, during the presentation, it was hard for me to follow the comments, but after I was able to read through, very interactive, and we also had fellow colleagues. Dr. Mary Ellen was very actively answering questions. So thank you, team, for being active. Mike, and also, of course, Dr. Kabweru and Andrew and Cleophas for the whole facilitation. My concluding marks is that please do not forget your clinical skills. As I mentioned, most of the emergencies actually, like life-threatening conditions in chest trauma, you don't have the time to actually do a chest X-ray, to do a CT scan. You know, if the patient will die, they will die. So your clinical skills are absolutely a game changer for these guys. So go back, practice. How is that trachea meant to be? How are those breath sounds meant to sound? You know, how is that percussion note? Is it normal? Is it abnormal? How is it? Because those small things actually make a huge difference in patient outcomes in the first few minutes of injury. Thank you very much.
Thank you very much, Dr. Justine. Now over to you, Dr. Kabweru. Closing remarks.
Thank you very much. CD Global, they are our friends. I now have been here several times on Zoom, and this is my first time to appear here physically. And the truth is that we are always very busy. Monday, Wednesday, Friday, we're in theater, and I left to the team, continuing to do thoracotomies. But this is my call to the whole country. Mulago is a public hospital. We, the teachers, we are available. When you have free time, pass around and you go through casualty and learn and go through CTS. Free learning. There's no toxic knowledge, and you can keep it for ages, and it only explodes when emergencies happen. So I'm going to ask Margaret, please, if you are not going to do a rotation on my ward, in your free time, pass there, and you put some chest tubes before you go, because at the end of the day, you will save so many lives. Even you may also save mine. You never know. We are all potential patients. Otherwise, I thank the team that have really discussed with us today. John, Justine, please, when you come to Kampala, say hi when you come to Mulago. You're always there, Monday to Monday. And Cleophas, obviously, Ibrahim and Thomas, we have been there. I don't know who told them that I should come. They are very good people, and I appreciate. And we also thank our emergency medical services as well, and then the Minister of Health for thinking big and getting such good partners to work with. Please, in case of anything, please always keep us posted, and we thank you for the help that you extend in terms of capacity building for more than my country.
Thank you, Doctor. Thank you very much. I'm also very grateful for all the panelists that we had today. It was a very great conversation. It was a very good discussion, and I'm also very happy. So there is the director of Moroto Regional Referral Hospital was like, services are always there. It's us that don't know how to use the services, and it is true. We have regional emergency medical services, ambulances in all regions. Now, Red Cross also has ambulances which are there for trauma. So people, you should use all these services. For the Red Cross ambulances, they have even a toll-free number as well, 0800-211-088. You can use those services for free, and your patients will be saved because we are here to save their lives. Thank you very much.
So I'd like to thank all the audio participants who are coming for today's session. At this point, I would like to request all of you to turn on your videos so that we can take a screenshot. Our next session is going to be in 2 weeks, and it will be about abdominal and pelvic trauma. So stay tuned. It will be as action-packed as today's. Turn on your videos for a minute or two as we take the screenshots.
Also, the internationals that we've had from Liberia, Nigeria, so Namibia. Any of you has a comment, we shall be happy to see you give comments.
Hello. Hello.
Yes.
I'm Dr. Mahmoud from EAW Hospital in Liberia. I'd like to say thank you to all of you for the presentation. It has been very informative, and I have been able to learn so many things today, so many new things that I know. And I look forward to the next presentation. Be very much excited if I'm invited. Thank you very much. Very great presentation.
Thank you so much. We are happy to have had you. Any other international? Dr. Mary Ellen, thank you for answering our questions. Do you have a comment to give? Okay. Any internationals? Dr. Mary Ellen, you want to give a comment?
So no, I mean, it was a great presentation. Thanks to the excellent panel. It was great.
Welcome.
I think it was an excellent presentation. Dr. Dabota Bowari from Nigeria. Thank you.
You're welcome.
You're welcome.
So greetings, everyone. So, this is Oliver from Kenya, and we are loving the presentation. So we are looking forward for more of these, and keep up with a good job.
Thank you. Thank you so much, Team Kenya.
Hello, everybody. Greetings from Namibia. Thank you very much for such an informative session. Looking forward for more sessions from now. My name is Mary Muyenga from Namibia.
Thank you so much, Mary. I'm saying Rania.
Hello, this is Dr. Rania from Sudan. Thank you for the great presentation. I'm looking forward to hear from you other presentations soon. Thank you.
Thank you, Team Sudan.
Hello, good afternoon. This is Nathan Apia. I'm an emergency nurse working with St. Francis Xavier Hospital in the central part of Ghana. I really enjoyed all the part of the program. Thank you so much for adding us to your program. Over.
Thank you, Team Ghana. Thank you for attending. Keep up the good work.
Greetings, everyone. I'm Christandos from Namibia, a student nurse at UNAM. It was a very nice presentation. Thank you very much.
Team Namibia, thank you. You should also share the links to other people to join in. We are happy to have you.
All right, thank you.
All right, all of you, thank you so much. We want to wish you a very nice weekend. Please do not drink and drive. You're going to get blunt or penetrating chest injuries, and it will not be easy to such chest tube.
Kabweru is here, I will do that.
So to the REACT team members that have attended, thank you so much. We are going to follow up with physical trainings to the resuscitation action team members. And the hospitals where we haven't visited, we are on our way coming. Thank you so much. Bye-bye, all of you.
Bye.
Bye.
Bye. Thanks very much.